How do we manage these chemical injuries? Chemical injuries to the eye are a form of ocular emergency and they need to be managed immediately. Management should start even before taking a detailed history and visual acuity. So the first line of managing a chemical injury is doing a thorough irrigation of the eye. So copious irrigation for 15 to 30 minutes is recommended for a chemical ocular injury. The common irrigation solutions which are used are normal saline, ringer lactate or balanced salt solution. Then we need to evert the upper lid as we see in this picture here, and we need to further irrigate the fornices because some chemicals can go and get lodged right there. So we can also do a double eversion, go further underneath and give a thorough saline wash and remove any form of chemical which is lodged there. So this is the first line of management. A thorough saline wash is extremely important in cases of chemical ocular injuries. Next step is debridement. So a necrotic corneal epithelium should be debrided to allow proper migration of the adjacent viable epithelium. The devitalized conjunctival epithelium should also be debrided to remove any nidus of persistent inflammation which can retard or hamper the corneal re-epithelialization. So this is the next mode of treatment, which is debridement of the cornea. So what is the medical line of management for chemical injuries? So one of the most important problem which is happening there is inflammation. So we need to start the patient on topical steroids. This is to decrease inflammation and neutrophil infiltration. And it also helps to decrease the anterior chamber reaction. But it's very important uh, to see that steroids are tapered. So we start instilling it around 4 to 6 times a day, and we slowly have to start tapering them. The other drugs which we can start the patient on are cycloplegics. The commonest one which we use here is atropine. Lubricants or tear substitutes have also got to be started. Topical antibiotics for prophylaxis of bacterial infection. You can also start the patient on ascorbic acid, which improves wound healing by promoting the synthesis of collagen by corneal fibroblasts. So they are either available topically or orally. Topical is 10%, has to be instilled 6 to 8 times a day. Oral is 1 gram twice a day. Citric acid is a calcium chelator, which is a powerful inhibitor of neutrophilic activity. It decreases the intensity of the inflammatory response and also inhibits collagenase. So topical again is available as 10%, should be instilled 6 to 8 times. Oral is 1 gram twice a day. So these are all adjuvant treatment modalities which have to be started. Tetracyclines are also given, which are collagenase inhibitors, which decrease neutrophil activity and also decrease the ulceration of the cornea. Apart from this, there is a lot of supportive treatment which we need to give. We need to patch the eye after instilling antibiotic eye ointment, which can increase the healing. Bandage contact lenses are also to be used if there is a lot of photophobia and extensive corneal damage. Symblepharon formation can be prevented by lysis of adhesions with a sterile glass rod. So we take a sterile glass rod, put some amount of antibiotic at the edge, and we sweep the fornices. So that is extremely important here. IOP has to be monitored, and if in cases where the IOP is high, we need to start the patient on oral acetazolamide. There are different modes of surgical management, which include limbal stem cells transplant, amniotic membrane transplant, tissue adhesives, keratoplasty, mucous membrane grafts, and keratoprosthesis. The limbal stem cell transplant is again of two types, the autograft or allograft. Autograft involves harvesting of the limbus of the patient's uninjured or less injured contralateral eye. So we take the graft from the other eye, and two crescents of peripheral corneal limbal epithelium is taken. So we see in this picture here, we take a strip of a peripheral corneal epithelium. So two strips, one from above, one from below. A corresponding section of the conjunctiva is also removed as shown in the picture. So limbal epithelium along with a part of the conjunctiva is removed. The allograft transplant, here is the stem cells are got from a living relative or a cadaver. This is usually done in case of bilateral injuries where it is difficult to harvest tissue from the contralateral line. Next is the amniotic membrane transplant. The amniotic membrane is the innermost layer of placenta. It consists of a stromal matrix, a thick basement membrane, and a single epithelial layer. What this helps with is it promotes re-epithelialization, it decreases the ocular surface inflammation, decreases the vascularization, and also prevents scarring of the cornea. Tissue adhesives like fibrin glue can be used in the management of impending perforation, where there is a possibility of perforation to happen if patient strains or coughs, or in cases of actual perforation where the perforation is not there. If it is around 2 millimeters in size, then we can use this tissue adhesive. Beyond that, it is a little difficult to use a tissue adhesive. Keratoplasty can be done in advanced cases. Tectonic keratoplasty is used in urgent setting of acute perforation where your tissue adhesives also cannot be used, like larger perforations. Penetrating keratoplasty can be done only after ocular surface rehabilitation, which is once the inflammation subsides, because if you do it before that, there is a possibility of graft rejection which can happen. If we do a limbal stem cell transplant, we can do it before or with the keratoplasty. The mucosal membrane grafts are useful in fornix reconstruction associated with conjunctival cicatrization. They are also useful in semblefron formation, cicatricial entropion, and trichiasis. So these are all complications of chemical injuries, and in most of these cases we can use mucous membrane grafts, mostly which is got from the oral mucosa. So last resort is keratoprosthesis. This is useful in bilateral severe chemical injuries where the prognosis is bad for a penetrating keratoplasty. That is, in spite of, even if you do a penetrating keratoplasty, there is a high likelihood of it failing. So these are pictures of keratoprosthesis, which is used in really severe chemical injuries.